Good afternoon. Welcome to the last of our four-part webinar series on food pollution, presented with the Alliance of Nurses for a Healthy Environment, American Holistic Medical Association, Safer Chemicals, Healthy Families, and others. Healthy Food Action is a 3-year-old network that educates and empowers public health, dietetics, nursing, medical, and psychology professionals to be advocates. Advocates for policies that will bring about the food and farm system that Americans want, food systems that are both healthier and more sustainable. Making sure today's webinar runs smoothly is my colleague Rachel Gruelle. I'm David Wallinga, today's moderator and the Director of Healthy Food Action. Kicking off today's webinar is Dr. Sarah Janssen. Sarah is a physician scientist with a broad background in reproductive physiology, clinical medicine, and public health. For over 20 years, she's studied triclosan and other toxic chemicals, many of which interfere with hormone function, reproduction, and development. Dr. Janssen is a staff physician in occupational medicine at the University of California, San Francisco. Excuse me, I've got to get my slide back up on the screen. Thank you. She is boarded in preventive medicine with a PhD in reproductive physiology from the University of Illinois, Urbana-Champaign, and she's currently a staff physician in occupational medicine at the Kaiser Permanente Medical Group. She's trained there as well as at UCSF and has an MPH from UC Berkeley. She's worked in policy advocacy, currently as a board member of San Francisco Bay Area chapter of Physicians for Social Responsibility, and previously with the Natural Resources Defense Council. Our next speaker will be Beth Schenk. Elizabeth's a nurse researcher and sustainability coordinator for Providence St. Patrick's Hospital, a regional center in Missoula, Montana. She has a nursing PhD from Washington State University, where she focused on environmental impacts of nursing practice. In our Q&A period, we're also going to hear from Trevor Russell. Trevor's Director of Watershed Programs at the Friends of the Mississippi River, and he's going to speak to us about some policy developments around triclosan in Minnesota. On this logistics page, you'll see how during our Q&A session, you'll be able to submit a question. Don't wait until after our speakers finish to submit questions. Earlier is better. On your menu, just look for the box on the right-hand side where it says Enter Question. Type your question and hit Send, where Rachel Gruelle will be able to monitor them and at the appropriate time feed them to our speakers. And now for the first of our speakers, Dr. Sarah Janssen. Sarah?
Thank you, David. Can you guys hear me okay? I'm gonna assume so, and I'm gonna go. So thanks for having me. I'm going to start off by just giving a little bit of an overview of the antimicrobial use in both consumer and healthcare products. There are over 2,000 antimicrobial products on the market. It's a $1.4 billion market just in the U.S. And one of the most commonly used antimicrobials is triclosan. It's found both in consumer products, everything from dish soap and hand soap to toothpaste, acne creams, body washes, deodorants, cutting boards, mouse pads, and even so-called anti-odor clothing and shoes. It's also used in healthcare in many of the liquid soaps that we have in our clinics and in hospitals. And I think interesting for me as a clinician is that the concentration of triclosan that's used in healthcare products and liquid soaps is 0.3% most often. And that's the same concentration of triclosan that's used in many of the liquid soaps that you could buy at your local drugstore or grocery store. Triclosan's been found in about 75% of liquid hand soaps. When it's used in personal care products, such as soap, or dish soap, it's regulated by the FDA under the Federal Food, Drug, and Cosmetics Act. When it's used in non-personal care products, things like cutting boards and shoes or clothing, it's regulated by the EPA under the as a pesticide. Next slide, please. So there are a lot of health concerns about this widespread use of triclosan in so many products. We know that it's readily absorbed across both the skin and the mucosa inside of the mouth. Biomonitoring studies done by the U.S. Centers for Disease Control have found that over 3/4 of Americans carry measurable levels of triclosan in their bodies. Because your body eliminates about half of the triclosan you take in within 11 to 12 hours, it means that because we can so consistently measure it in people, that we're taking it in about as quickly as we're getting rid of it. Here in California, we have our own biomonitoring program, which last fall revealed that over 95% of the samples that were tested here in our state had measurable levels of triclosan. And another study done with some college students over in Europe had them brush their teeth. They got paid to brush their teeth just like their parents told them to when they went away to college, twice a day, every day for 2 weeks. And they found a dramatic rise in their blood levels of triclosan. On average, it was a 450-fold increase. But for one of the participants, it was over a 1,000-fold increase in levels of triclosan in their body. So the everyday use of triclosan can result in significant exposures in people. It's also been found in breast milk, which is, of course, a concern for a developing infant. Next slide, please. Healthcare workers wash their hands a lot more than the average person, sometimes 30 or 50 times a day. And so as a clinician myself, I've been concerned that healthcare workers might disproportionately be exposed to triclosan because of their use of triclosan in the workplace. We did an experiment. It was a relatively small experiment here in San Francisco where we looked at exposure in physicians and nurses. We had 76 participants. One group worked in a facility that had eliminated triclosan soaps in all of their clinics and hospitals, and the other facility had a triclosan soap, the 0.3% concentration. And we compared levels of exposure in both groups. It turned out, we didn't plan it, but it turned out that about equal numbers of people used Colgate Total Toothpaste, which is the only toothpaste in the U.S. market that has triclosan. So when you looked at just the gross numbers between the two groups, the average was about the same, and it was because of the high use of triclosan toothpaste in both groups. When we took away those people who used the triclosan toothpaste, we still found that there were significant differences in exposure due to use of, presumably due to use of the triclosan soap in the workplace. On average, the people who worked in the hospital where the triclosan soap was used had 7 times higher levels of exposure than those who worked in the hospital where they didn't use the soap. And we also found that independently, both use of triclosan toothpaste and use of triclosan soap were found to contribute to a person's overall triclosan exposure. This work was funded by NRDC. It's a study that I worked on while I was working there, and it's just been accepted for publication in the Journal of Occupational and Environmental Medicine. Next slide, please. So the thing about using triclosan is that it's really an unnecessary exposure because it doesn't work. It's no more effective than plain soap and water at eliminating bacteria from the skin. There's been a number of studies done which show that it doesn't really reduce illness. It doesn't prevent viral or bacterial infections. The FDA has even admitted that it doesn't work. It's no better than plain soap and water. The concentration that's most commonly used in everyday products, the 0.3%, is bacteriostatic, which means that it doesn't actually kill bacteria. It just keeps them from multiplying, which is why there's no reduction in levels of bacteria on the hands after washing with the triclosan soap. At higher concentrations, triclosan is bactericidal, meaning it does kill bacteria. But one of the problems is that it's really good at killing gram-positive bacteria, but not so good at killing gram-negative bacteria. And gram-negative bacteria are some of the bacteria that we worry about the most when it comes to hospital-acquired infections, things like Pseudomonas and Serratia. And in fact, there's been a couple of instances where there were outbreaks of infections on hospital floors, Unfortunately, people even died from these infections, and they were traced back to the triclosan-soap dispenser, which was harboring these bacteria. So I know it's been written that triclosan is a necessary, has necessary uses in hospitals and in healthcare settings, but I don't buy that, and I don't really think that it's a good idea to use this chemical in our healthcare institutions. Next slide, please. Triclosan has also been shown to have a number, and actually kind of a surprising number of different types of health concerns. One is hormone disruption. It's been shown to interfere with a number of different steroid hormones, including thyroid hormone, which is important for development of the brain and nervous system. It also interferes with testosterone, causing a decrease in sperm counts, and interferes with estrogen action, resulting in an earlier onset of puberty. These were all studies done in animals, but there's no reason to think that we wouldn't be experiencing or seeing similar effects in human studies. A really interesting study came out last year showing that triclosan also interferes with the ability of muscles to contract, both heart muscles and skeletal muscles. And again, these were done in animal studies showing that triclosan exposure at everyday concentrations was shown to weaken muscle contractions, resulting in a decrease in heart function and also in grip strength. When added to water, where minnows were swimming, it interfered with their ability to swim. Many decades ago, the FDA recognized that triclosan and its chemical cousin triclocarban both cause tumors in the liver and thyroid gland. And then more recently, some studies have associated it with the development of allergies, in particular some food allergies. Next slide, please. And then one of the last concerns that I wanted to raise about triclosan is that in addition to not working very well as an antibiotic, it also has the potential to promote cross-resistance to other antibiotics, which we rely on to treat infections in humans. As a clinician, one of the most concerning things to me is that triclosan's mode of action for how it interferes with bacteria is that it has the same mode of action as INH, or isoniazid, which is an antibiotic that we rely on for treating tuberculosis. And so there's potential for triclosan to cause cross-resistance for that drug, which we already are seeing a lot of resistance in for tuberculosis. It's already becoming a disease that's very hard to treat. Other laboratory studies have demonstrated cross-resistance to a number of other antibiotics, including ciprofloxacin, erythromycin, tetracycline. And so while this hasn't been shown out in the real world, it's only theoretical because of laboratory studies, I think it is a real world concern that triclosan could be contributing to the rise in antibiotic resistance. Next slide, please. So when we wash our hands with triclosan soap, when we brush our teeth, or when we're washing our dishes with an antibacterial dish soap, that chemical doesn't just get absorbed into our skin, but it also gets washed down the drain, where it goes to the sewage treatment plant. Triclosan preferentially accumulates in the sludge, so there's not very much of it that's coming out into the wastewater. Next picture. But instead, most of the triclosan, and again, its chemical cousin triclocarban, which is found in bar soaps, is found in the sewage sludge, which is then treated and used as a fertilizer in our farm fields as biosolids. And so there's actually pretty high concentrations of these chemicals in biosolids, and there have been a number of experiments which have shown that under the similar conditions in greenhouses with biosolids and water containing similar levels found out in the community, that the plants are actually able to take up triclosan and triclocarban into their roots, and then into the fruits or into the vegetables. So next slide. There have been a couple of studies published which have demonstrated that both of these chemicals can be found in soybeans, zucchinis, pumpkins, and some of the root vegetables like carrots, which I think is also a real big concern, because even if we get rid of these chemicals in our everyday household products, we might be consuming them in our food. And next slide, triclosan also, of course, when it's put out into the environment, ends up in wildlife. It's been shown to interfere with the survival and reproduction of a number of water species. There was an article written recently which said that triclosan and triclocarban are 100 to 1,000 times more effective at inhibiting and killing algae, crustaceans, and fish than they are at killing microbes. It's also been shown to, it's also been found in bottlenose dolphins and to be accumulating in the earthworms that are living in these biosolids treated fields. So next slide. So, you know, I think a lot of us assume that because we can buy these products and they're on store shelves and they're regulated by the FDA, somebody, you know, has vetted them for safety. In fact, these, like I said before, the hand soaps are regulated through the Food and Drug Act, and they're not supposed to be marketed unless they are found to be both safe and effective. And FDA regulates both consumer hand soaps and healthcare hand soaps. And they have 3 categories, next slide, for how these products are put on the, or for how these products are evaluated. The first category is that they're generally recognized to be safe and effective. That's category 1. That's like the green light. The red light, take them off the market, is category 2. That's conditions where they're not recognized to be safe or effective and are misbranded. And then category 3 is sort of the catch-all yellow light category. We don't have enough data to know whether they're both safe and effective. So there are currently no products on the market in category 2, but you could probably guess where most of the products fall, category 3. Next slide. So see, these are some of the products that FDA has looked at, and they've lumped them all together into one document that they call a monograph. And in that monograph, they've divided them into healthcare use and consumer use. So see, these are some of the chemicals that are that have been looked at by FDA for use in healthcare. And you'll see right at the top, alcohol and iodine both meet category 1 requirements. They've both been shown to be safe and effective. And everything else below it is either category 2 or category 3. Hexachlorophene was taken off the market when it was found not to be safe or effective, but all the other drugs that are there still are in use on the market, including triclosan. The last one that I have there, chlorhexidine gluconate, which is commonly used as a surgical prep scrub, actually was developed after the monograph came out, and it went through a separate approval process and has been shown to be safe and effective, but it's not covered through this monograph. Next slide, please. So the drugs that are used in consumer soaps are not that different from the ones that we find in healthcare soaps. Again, alcohol, like your hand sanitizers, meet category 1. They're shown to be safe and effective. Everything else, including the quaternary ammonium compounds, triclosan, triclocarban, fall into this category where there's not enough evidence to show whether they're safe or effective. Now, next slide, please. So if this monograph had been finalized, it was started in 1974. It underwent a couple of revisions and was last updated in 1994. If the monograph had been finalized as it was written then with these current categorizations, it wouldn't have been legal for either triclosan, triclocarban, or the quaternary ammonium compounds to be used because they hadn't met the bar of being both safe and effective. But through a loophole in the law, because this monograph is still tentative and has never been finalized, they are allowed to be freely marketed and sold. So they've never really been approved by the FDA. They haven't met the bar of being of safety and efficacy. But as long as we are in this limbo, they can be used and they can be labeled as antibacterial. FDA finally, at the end of last year, made a little bit of motion in this direction. They put out a proposal for a final rule, which will require manufacturers to prove that their antibacterial soaps and body washes are safe and more effective than plain soap and water. And if they can't demonstrate that, they're going to have to be reformulated, relabeled, or possibly removed from the market. The expectation for when that final rule will happen is another 2 years from now in 2016. So in, next slide, please. This is something that I already said, that basically for 40 years, we've had these products on the market with essentially no oversight. Next slide. So in lieu of any federal regulatory action, a number of institutions and organizations have taken it upon themselves to remove unsafe products. One of them is Kaiser Permanente. They eliminated use of all triclosan hand soaps in all of their facilities. And they also recommended that they didn't use any antimicrobial impregnated fabric, paint, or building materials because they cost more and they aren't shown to be effective. Both the American Medical Association and the California Medical Association have also passed resolutions calling for the reduction in use of antimicrobial products. Next slide, please. A number of municipalities have also taken measures to discontinue purchasing antimicrobial, antibacterial, or triclosan soaps. Here in California, a number of Bay Area groups have done it. The state of Minnesota, you're going to hear more about later. Next slide. And then more recently, a number of companies have announced publicly that they're going to remove triclosan and other chemicals from their products. I think it's interesting, Colgate-Palmolive said that they would take it out of their products, except not their toothpaste, which has undergone a separate FDA approval process for treating gingivitis. Next slide, please. So a number of replacements have come out, and I didn't mean to pick on particular brands, but I wanted to show you this for the sake of labeling. So soft soap used to have an antibacterial soap. They took triclosan out, and now it's just plain soap and water, but the label says instead of, I think it used to say kills bacteria, it says washes away bacteria, which is entirely true because that's what plain soap and water do. Other alternatives, as I already mentioned, are the alcohol hand sanitizers or just regular plain soap, plain old bar soap, not deodorant soap, not antibacterial soap because that will have triclocarban, but just plain old soap does the job just as effectively. Trader Joe's and I think a number of other manufacturers of antibacterial soaps took out triclosan, but they still have an antibacterial soap on their shelves, and they've replaced triclosan with a quaternary ammonium compound called benzalkonium chloride. And I think it's interesting if you look at, in particular, this soap on Trader Joe's website, it says, we formulated this soap to be free of parabens, phthalates, sodium lauryl sulfates, making it sound like it's a really healthy, good-for-you soap, but it still has an unproven, untested, and maybe even unsafe chemical in it that's not needed at all for effectively washing your hands. And I think that's one of the concerns is that when we get rid of one chemical, often another one pops up to replace it that hasn't been as well tested. And because of the limitations in our federal system for vetting chemicals for safety before they're put on the market, it's perfectly legal for them to do this. Next slide, please. I think this is my last slide. So the consumer advice is that you just use plain soap and water or use an alcohol-based hand sanitizer. Avoid buying things that are labeled being antimicrobial. One of the advantages with triclosan, triclocarban, and the other antimicrobial products is that they actually do show up on the label because they are active ingredients. So you can turn it over and you can see exactly what is in there and what concentration. And then finally, I kind of wonder, nobody's actually gone out and bought food and tested it for triclosan, but I sort of wonder if you bought organic food, which is grown in fields that aren't treated with biosolids, if it would also help reduce exposure to triclosan and triclocarban. And the last page is just resources, which I know that David's going to also send out to everyone. Thanks for your attention.
Hello, this is Beth Schenk in Missoula, Montana, and thank you to David and others for inviting me to speak as well today. And great presentation, Dr. Janssen. I've heard you speak before, and that was in part what helped push us to do the work that we've done on reducing triclosan at our hospital and now moving across our system, which is Providence Health and Services in 5 western states. And I've titled this Reducing Triclosan because we have not completely eliminated triclosan because it comes in insidious ways. Through our cardboard boxes, for example, I've found that that's one of the hardest places to make sure that you're not bringing in triclosan because it's so commonly used in shipping. But I want to tell you about our story here at St. Pat's. This is just a case study that will be fairly brief. Next slide, please. So as Sarah said so clearly, in identifying the problems with using triclosan, there are many reasons why we were concerned, from the environmental damage, especially in our waterways, that it is so present in human beings. We don't know the direct effect on human beings, and this became a contentious point in our case, that it can lead to antimicrobial resistance and that we have better alternatives. And if you look at this image from the Skin Deep database that's offered by the Environmental Working Group, if you haven't used it, it's a great website that has green, yellow, and red readings. And the higher the number, the less safe something is. And if it's red, the less safe. So this is a 7 out of 10 for triclosan. It's red. So that added to a large pile of evidence and information that I had compiled in this effort. But this image sort of helps paint the picture. Next slide, please. So what we wanted to do, and I had been concerned about this. First of all, I am the sustainability coordinator, as David mentioned, here at this hospital and work with a number of other hospitals. And we have a full program of energy efficiency, reducing waste, reducing chemical exposure, and engagement of staff and the public. And so this is certainly an issue in our efforts to reduce chemicals, both for our community, for our patients and visitors, and for our staff. And this one, for triclosan particularly, had come up a few times from staff concerns and from me, from my own studies and work. And so we wanted to address it. We began addressing it about 2 years before we were able to accomplish much, because as you might guess, there's a fair amount of pushback in hospitals about infections. And that's because, rightly so, we are completely committed to preventing the spread of infection. And it's a high priority. We measure ourselves on it. We hold ourselves very accountable. We have an infection control physician and an infection control nursing staff. So it gets a lot of attention, and everybody's concerned about spreading infection. So first in conversations, it just didn't go very far because of this concern and because of really a resistance or a fear of taking away one of our perceived weapons or a bit of our arsenal against infection, and that is the use of antimicrobial soap in all locations. So what we had before was a soap that had triclosan in it, and we used it universally everywhere. That's in our clinical areas and non-clinical areas. So we talked about this off and on, like I said, for about 2 years, presented different studies, different evidence, and a physician had gotten involved with me as well, and we compiled a summary of the evidence, including some of our email conversations with the CDC and our examination of current resources and papers about healthcare use of antimicrobials in particular. And troublingly, there's not a real clear evidence. As Sarah pointed out, there's good evidence from respected sources, including the AMA, about using non-antimicrobial soap at home. But people are a little bit more reticent to come out and make a statement at hospitals. So it ends up being an independent decision. And even APIC and the national groups that support infection control don't make a clear statement about this. So we use basically the precautionary principle that if we have a better alternative and we have known risks, let's see if we can take the less risky alternative. So what we did, it's not a perfect solution because we're still using an antimicrobial in some areas, and that is chloroxylenol, which Sarah mentioned was a class 3. It still doesn't have enough evidence. But if you see, for instance, on this simplified explanation, it is a 3 out of 10 rather than a 7 out of 10, and it's in the yellow phase rather than the red phase. But I think the main thing, or the thing I feel most accomplished about with this, is that we've made a significant reduction because we've split our system into 2 soaps. And this was also got resistance from our environmental services staff, concerned about cost, concerned about keeping the soap straight, concerned about labeling, et cetera. And so we worked it out with everybody that we would go to 2 soaps. So we have plain soap with no antimicrobial in public areas, restrooms, office areas, really a majority. It's probably about 80% of all of our soap dispensers are of that type. And then we moved to this other antimicrobial, which we perceive as safer, but I totally acknowledge that we don't know, and this is part of our problem. And that is in patient rooms, and it's in nurses' stations, and it's in high-touch, high-risk areas like cath labs and that sort of thing. So what I think is, as some of you know if you're clinicians, the recommendation for hand washing for hospital staff is when hands are visibly soiled and after using the restroom. The rest of the time, the recommendation is the alcohol-based hand sanitizer. So that means that really much of the time in and out of patient rooms, you use alcohol-based and then put on gloves. And you come out and you use alcohol-based. You go in and out with the alcohol. And then when you wash your hands after using the restroom, nurses and others are exposed to plain soap. So really, I think, and I've talked with my infection control staff about this, that we've cut down exposures to clinical staff of any antimicrobial by 80 to 90%, and in some cases, some days, it would be 100% because people wouldn't ever have to use the high-touch soap. Next slide, please. So what we did to do this is we first trialed this new antimicrobial soap on one nursing unit, and we watched for skin sensitivity or other complaints, and really didn't have any. We gave staff a chance to report out, and the infection control nurse did talk with some people. So without any reports, we went ahead and installed the 2 new types of soap. So you can see the picture on the left. We used to have a soap that said this on the containers, which was a constant reminder, to me anyway, that we had triclosan in our hospital, which was troubling. 2, this other sign on the right. You can also see that, and this was important for us internally, that it was the same company that provided the soap. We didn't have to change out all the containers, the dispensers. That was important to me as a sustainability coordinator as well. I didn't want to have hundreds of plastic containers to have to discard or even recycle. And so it went very smoothly. Next slide, please. So we've watched what happened, of course, and we were very concerned about any infection or any issues. So a year later, we had no reported issues with skin sensitivity. That was important. The staff liked it just fine. We had no increase in infection. In fact, we did show a decrease in C. diff infections. But I don't say that this is just because of the soap change, but I do say that we certainly didn't have an increase in infections related to the soap change or going to plain soap in our non-acute areas. Also, we saved money, so that helped, of course, and that also helps the spread of this throughout Providence. And so at this point, there are another 5 and maybe 6 hospitals who have adopted this 2-soap method and have eliminated triclosan, and that's out of 33 total. So we hope to continue to move that across the system. I've had opportunities such as this one and others to discuss this with clinical staff across the nation. I think that's helpful to just have a case study. And also, as Sarah said, Kaiser has done this well, and I talked with their purchasing staff about this before we moved ahead. And then this is an important message to our community because we want to protect community health. We think we are protecting community health, and we can show our results now that we're protecting not only ourselves and our staff and patients and visitors, but also our aquifer and our rivers right here. Next slide, please. And this, too, is a list of resources that I think David has to share with you all. And my last slide is just my contact information, which I think he will also share. Thank you.
Well, thank you, Beth. That was great, and Dr. Janssen as well. Wonderful presentations. We're going to get to the Q&A in just a minute, so I want to prompt folks to send their questions in via the question function. And we because of the number of attendees, we've got to kind of vet the questions and pony them up for the speakers. But first, just to give us a little flavor about what's happening in terms of policy in response to some of the science we heard, I wanted to have Trevor Russell speak for a couple of minutes, and I introduced him earlier. So Rachel, please unmute Trevor and let him just spend a couple of minutes talking about kind of the context here in Minnesota. Okay, Trevor, I think you're good to go.
You've self-muted yourself, so you're going to need to unmute in order for the audience to hear you.
All right, why don't we give him a chance to work on that, Rachel, and just pony up a question first, and then he can prompt us on chat when he's
Folks,
you there, Trevor?
Can you guys hear me okay?
Yeah.
Okay. Don't know what happened there. Well, I'll just briefly let folks know my name's Trevor Russell. I'm the Water Program Director with Friends of the Mississippi River. Next slide. You may ask yourselves why a water quality organization is involved in this kind of conversation, and this came to our attention in 2012 when we published the State of the River Report, and we looked at indicators of water quality and river health in the Mississippi River. One of those indicators was triclosan. Next slide. I'm going to really briefly walk folks through a three-step process that leads to some serious pollution issues in the Mississippi River, but I want to say that I'm bringing this up because this issue, along with all of the other issues we've heard about triclosan, has generated a tremendous amount of media coverage, and that has provided us with momentum to advance state policy in Minnesota. Next slide. The biggest issue with triclosan from a water quality perspective is dioxin pollution. This is a three-step process where products that contain triclosan go down the drain. Here we'll use the example of liquid hand soap. Recent research in Minnesota suggests about 95% of that moves just right down the drain. A remaining portion stays in the immediate environment, some of which is then expelled as waste back into the wastewater treatment system. Next slide. While we noted earlier that most of the triclosan is removed in biosolids, some of it does move through the wastewater treatment system because those systems are not specifically designed to remove triclosan. More troubling, worse yet, some of the triclosan binds with chlorine during the disinfection process and forms a new compound. That new derivative is also flushed into the river. Next slide. Both compounds, when exposed to sunlight, photodegrade and form dioxins. Dioxins are persistent, potent carcinogens that stick around in our environment and accumulate up the food chain. Next slide. And then here's sort of the money shot for us. Triclosan-derived dioxins have increased by 200 to 300% in Mississippi River sediment samples, while all other levels of dioxins have decreased from about 70 to about 95%. Thus, triclosan is now the largest source of dioxins to Minnesota's surface waters. Next slide. This, as you imagine, captured some public attention, and we worked with legislators and the governor's office to secure Governor Dayton's March 4th, 2013 executive order prohibiting the state from purchasing any products that contain triclosan. I do want to note that the prohibition included a waiver allowing any entity in state government to petition for a waiver from the ban if they found that triclosan was necessary to perform their functions. 13 months later, you would all be surprised to know no one has applied for that waiver. We also advanced two legislative initiatives, Senate File 1166 and House File 1332, that were to phase out triclosan in all personal care products with exemptions for medical facilities and food processing facilities. Next slide. Those efforts have run into two of my very good friends at the Capitol, Senator Metzen and Senator Dill. Next slide. And both of those gentlemen have been instrumental in thus far stopping legislation from moving. In 2013, the Senate blocked passage of the bill despite its passage originally in the Environment and Energy Committee. This was opposed by the Minnesota Chamber of Commerce and the American Cleaning Institute, and thus the House file never advanced because it was already blocked in the Senate. Next slide. Fast forward now to 2014. A second bill moved forward in the Senate. It did pass the Health and Human Services Committee, but my friend David Dill essentially whisper vetoed it, which is saying if it passes one more committee, I'm going to take it, put it in my pocket, and no one will be able to talk about it again. And so we are moving to a floor strategy instead. We're going to amend a bill on the floor of the Minnesota House of Representatives to include triclosan phase-out language. To do so, we need 69 votes. Currently, we have more than that committed to support the bill. Once that happens, that House bill will have to be reconciled with the Senate, and both chambers will vote, hopefully in favor. That vote should be secured by mid-May. So before the end of next month, we quite possibly will have a statewide ban in Minnesota on triclosan in soap and body wash products that would go into effect January 1st, 2016. Next slide. And that's a sort of a quick update from me. There are some additional initiatives moving forward, both on soap and body wash here, and legislators have asked for more comprehensive legislation to pick up things like toothpaste and other personal care products in 2016 and 2015. And the city of St. Paul is looking at a municipal ban. Minneapolis had one in 2006, though no one in the city knew that was in their ordinance until this process started. There's also legislation advancing in the New York State Assembly, multiple county efforts in Minnesota and in other locations. And I do want to point out one or two of these other additional activities. The Minnesota Department of Health is finalizing a study that I'm helping coordinate on how to communicate with consumers about triclosan in personal care products, what types of messages and messengers are most effective for encouraging people to switch to triclosan-free alternatives. And lastly, I'll mention that we did conduct comprehensive statewide polling on this issue and found that 69% of Minnesotans do support a legislative phase-out of triclosan, including 62% of people that acknowledge themselves as triclosan soap users. Next slide. For more information on anything that I've shared with you today, I do encourage folks to just contact me directly via email. And I do want to acknowledge the assistance that Healthy Food Action and a number of environment and public health organizations have provided in making everything you just heard possible. This is not FMR's initiative. I was just asked to report on it, but there's a large coalition of folks working to make this possible. That's all for me. Thank you all very much.
Great. Thanks, Trevor. I really appreciate that update on the Minnesota legislature. I thank Sarah and Beth for also speaking to us today. We have a number of questions available here. So I'm going to start off with a couple questions that came up directed to Sarah, specifically about triclosan in toothpaste. So the few questions came up asking about whether or not triclosan in toothpaste has been deemed safe and effective after review by the FDA, and whether or not toothpaste is a culprit for causing antibiotic resistance.
Okay. So the only toothpaste in the U.S. that uses triclosan is Colgate Total, and that's made by Colgate-Palmolive, who did go through a new drug application for the treatment of gingivitis. I think it's actually for the prevention and treatment of gingivitis. And it was shown to be effective for that use. I think the safety question is something that we've all wondered a little bit about, like what science did they use? Because much of the science that I presented has come out in the last 10 years, and that new drug application was based on science that's probably 15 to 20 years old. I know that, or maybe even older. I know that NRDC had requested from FDA information and documents about the science that they used to support the safety, and they got very limited data and have had to sue the agency to get what should be public information. So I can't answer how well they vetted triclosan for safety. In terms of will it contribute to antibiotic resistance, I think any exposure to any antibiotic on a daily basis at low doses of exposure has been very well documented to contribute to antibiotic resistance. Now, the question is whether triclosan itself does that, and it hasn't been demonstrated in the real world that use of triclosan products makes bacteria resistant to other antibiotics. So in the laboratory, yes. In the real world, no, because it's a very difficult experiment to do. Did I answer all the questions?
Yes, definitely. Thank you, Sarah. And there's a follow-up question. This one can be directed at Trevor, also about toothpaste and whether or not toothpaste would be included in the proposed ban of triclosan in Minnesota.
Thank you for that question. This year, We did not include toothpaste in the ban. We specifically tailored the language to focus on hand soaps and body washes. That was the preference of the lead legislator, and the concern there is that since the FDA has sort of loosely granted its approval for triclosan in toothpaste, we didn't want to confront sort of incongruities between state and federal law. I do want to point out that there is only one company, Colgate Total, that makes an anti-gingivitis toothpaste that uses triclosan. One of their biggest competitors happens to be Colgate Total, who also makes an anti-gingivitis toothpaste that is now triclosan-free and advertises its new active ingredient right on the box. So while toothpaste remains a serious concern for us, we are starting to believe that Colgate Total may be moving away from triclosan as it sees additional market pressure. So we hope that some combination of state legislative and market pressure could resolve that issue shortly.
This is Sarah. Can I just add one thing? That a very easy and effective way of treating gingivitis is to floss your teeth. You don't need chemicals to treat gingivitis or prevent.
Great. Thank you both. That was a wonderful answer to those questions. This question is directed specifically at Beth, and I think this one might have came in from David. I'm not sure, but this one's for Beth, and it says, Kaiser has written that they saved millions of dollars by switching out antimicrobial soaps. Have you seen any savings within your system in switching to alternatives?
Yeah, thank you for that question. We have seen savings, but not in the millions. Kaiser's bigger, and also they addressed all their hospitals at once, all of their hand soaps at least. And so at our particular hospital, it would be more in the tens of thousands, probably between 10 and 20,000 per year. And if multiply that times the 6 or 7 hospitals who have now adopted this. And part of that is because the soap and water soap is less expensive, but the antimicrobial soap that we are still using is more expensive. So in the end, it comes out in the wash, so to speak, that we have saved money, but I hope that we will continue to move in our direction away from antimicrobials and save more money and be safer yet.
Great, great. Okay, we have a few more questions here. This one is for Sarah. One of our audience members is wondering if you have a series of talking points for commenting on that FDA monograph that hasn't been finalized yet, or if there's a way kind of for our health professional audience to get involved in kind of moving that forward.
Yeah, I can give a little bit of an update on that. So the monograph has been reopened for comment in part because NRDC sued the agency in 2010 for failing for what was considered to be an unreasonable delay in regulating these, not just triclosan, but all the antimicrobial chemicals. So as a part of settlement agreement for that lawsuit, a number of deadlines were agreed upon, and including one which was reopening a monograph for comments. And so that comment period is currently open through the middle of June, I believe. And I know that NRDC, I'm not sure if there are other groups who are here on the phone who could also chime in that are going to be submitting comments. I don't have any talking points that I can readily send you, although I think it would be easy enough for me to generate some if folks are interested.
Sarah, could I jump in? This is David. You had mentioned kind of the lack of information about uptake of crops of triclosan into food crops. Is that something that the FDA has addressed in its assessment of triclosan to date, or would it be appropriate for them to address in the future?
Well, FDA doesn't regulate the use of biosolids. So I'm not sure that it's in their purview to consider that as part of the safety assessment. I mean, I think their traditional slant on what safety means has focused on immediate health effects to the person who's exposed to the chemical or drug. And I don't know that they have considered environmental effects very well. I know that in the law, there's a provision that they're supposed to consider environmental impacts, and that may or may not fall under that. That's probably more of a legal question. But I'm certain that it's not anything that they have ever considered before when reviewing the safety of these drugs.
Great. We've got a question here for Trevor, asking if there are any other states that are also considering an executive orders around triclosan outside of Minnesota.
My understanding is that the New York State Assembly has advanced legislation this year that would do the same thing. I don't believe that legislation is moving anywhere, and I didn't see a companion bill in the other chamber of that assembly. So I think that is just a single chamber effort in New York, and I don't know if that bill will or will not advance. I've been inquiring with their staff, but they can't tell me right now where that is moving. If Minnesota does pass this bill, we would be the first, and I suspect that other states would follow shortly thereafter. Minnesota has a lengthy record of beating the FDA to the punch when it comes to public health issues. So we've had some communication from other states that have told us we're going to wait and see how it goes in Minnesota before we move anywhere else. Minnesota has the advantage of having a lot of the water quality and dioxin formation related research sort of homegrown. And because we are at the top of the Mississippi River watershed, all of our water comes from our state. We don't get inflow from other states, and so our pollution problems are uniquely our own, and so we have a greater leverage at the legislature to advance that. I should also note that Minnesota currently has single-party rule in the governor's office and both chambers of the legislature. Should any one of those flip, both the House and governor's office are up for re-election this fall. It may be difficult for legislation to advance, so we have a narrow window of one session where we know we can get this through.
Great, thank you, Trevor. We've got a question. Oh, go ahead.
Sorry, this is Sarah. I just wanted to add that I don't know where it went, but last year the city of Chicago also introduced an ordinance to ban use of triclosan.
Oh, great. Great, thank you. So we have another question. This one's probably directed towards Sarah, and it's asking about how triclosan works. If it works like an antiseptic, and it's not necessarily an antibiotic, how does that contribute to antibiotic resistance? If you can speak to that.
Yeah, it's there's an enzyme in the bacteria cell wall called, I'm going to mispronounce it, but it's an enol something reductase that triclosan inhibits. And so protein transporters, enzymes that are in bacteria are susceptible to many different drugs, and the bacteria over continued time with low exposure to the drugs will slightly change the configuration of the protein so that it's no longer susceptible to the drug. And that's how bacteria develop resistance to many drugs. And it's not just to that particular enzyme, but to the many different transporters and enzymes that are, hundreds, maybe thousands of them in a cell membrane. And so when drugs are developed, they target a particular transporter. In this case, the transporter that triclosan targets is also the same transporter that the drug INH targets. And so that's why we're worried about cross-resistance for drugs that were currently being used. So the drug can just, I can't really speak to how, sometimes it kills when it kills the bacteria, it's probably not through that transporter. It's probably through some other mechanism that's toxic to the cell, and so it kills the bacteria. But when it's bacteriostatic, it interferes with the machinery in the cell that keeps it from dividing. So that's the difference between being bacteriostatic, which inhibits multiplication of the bacteria, and bactericidal, which would actually kill it. And I'm not a bacteriologist, so there's probably a more accurate scientific explanation than that, but that's my best attempt at answering that question.
And this is Beth. I'll just add, because this was of great concern to us in the hospital, and we needed to understand it a little bit. And so just by comparing that mechanism that Sarah just explained to alcohol, for instance, because people said, well, wouldn't alcohol cause the same things when we use so much hand rub in its alcohol form? And it actually opens the cells. It ruptures the cells and kills it. So therefore, it can't really evolve around. So that satisfied our infection control clinicians.
Great, thank you both. This question kind of piggybacks off that one a bit. It's specifically about drawing a link between triclosan body burden and illness in human beings, and whether or not either of you know of any studies that kind of clarify that question.
Well, that's a 64 or maybe $1 million question. I mean, it's the same question we have for any chemical that we're exposed to that we can measure in our bodies and links to human disease. It's a very, very difficult question to answer. We can't intentionally expose people, although we do it unintentionally, but we can't intentionally expose people to chemicals and then, wait 40 years to see what happens to them. One, it's very expensive, and two, it's not ethical. So there are almost all chemicals, when we're looking at their toxic effects, have to be studied in animals right now. We do have some non-animal ways of testing things, but for the most part, historically, the ways that chemicals have been evaluated for toxicity is to look at effects on animals, because the organ systems, hormones, the way the muscles work, all the things that triclosan's been studied in animals are exactly the same in humans. And we can assume that if we're seeing it in an animal, we're going to see it in a human. And chemicals are regulated all the time based on, well, maybe not that many chemicals, but the few chemicals that we have information on are regulated primarily based on animal studies. Often the human studies follow after the animal studies, and it takes a long, long, long time and millions of dollars to come up with often what are human results that corroborate the animal studies, but often are not probably enough by themselves, because humans are humans and they don't do everything exactly the same. We have different genetics, and also we're not exposed to one chemical at a time ever. We're exposed to dozens, if not thousands, of chemicals on a daily basis, and we don't know how the chemicals interact with one another.
Yeah, this is
Can I point out an irony here from a health policy standpoint, and that is that the speakers have talked about how 75% of soaps and sort of the consumer environment in general has triclosan, but without any evidence being put forward that triclosan is helpful in terms of being better than soap and water. And yet this question kind of puts a higher burden of evidence to remove triclosan from that environment. So it seems to me like ideally we would want to have the same questions being applied to taking something that we think might be harmful out of the human environment as to put it in the human environment in the first place. That seems to be more consistent health policy.
Yeah, I certainly agree with that. This question is one that certainly came up as we were trying to push people who were very cautious about decreasing any infection control efforts. And so that's what I found as well, that there were studies that showed effects of triclosan naturally occurring in our water animals, and also effects of triclosan in our lab studies, which were mostly on mice or rats, and none really on humans because of the reasons Sarah explained. At the same time, we see effects of hormone disruption throughout our population. We certainly see it in our nursing staff, my area of interest, in terms of diabetes, asthma that may be mediated by hormonal disruption, obesity, and it is such a giant mix of things that we're exposed to at different crucial times in our lives over repeated episodes and decades that it's really difficult to sort out. And I think, as you said, David, we just need to take a proactive, cautious approach rather than throwing it all out there on us for us to be the guinea pigs, and then it's too much of a mess to sort out scientifically. But it's frustrating, but there is movement ahead. At least we hope so.
Great, thanks, Beth. And I think we have just a couple minutes left here. One more question I'll throw out there. There's been a lot of discussion today about environmental toxicity, most of the measured concentrations of triclosan are actually much lower than the laboratory toxicity threshold values. Have you included evaluation of exposures at environmentally realistic concentrations? It's kind of a mouthful.
This is Sarah. I'm not sure I understand the question. It's a number of the studies that I presented that were done in animals were actually done at similar concentrations that have been found in humans. So it's what we've measured in people's bodies. And I didn't mention that what we measured in the healthcare workers was actually higher. It was upwards of the 90th percentile for the CDC and Haynes studies. So healthcare workers carry higher levels of exposure than the average public, one. And then two is like the study that was done of skeletal muscle and heart muscle contraction and the minnows swimming in the water. Those were all done at concentrations that are found in humans, as well as some of the allergy studies, which are human studies that have been shown to that concurrent exposure to triclosan has been associated with increased allergic reactions. I'm happy if the speaker wants to contact me, or if the person who asked the question wants to contact me directly, I'm happy to try to clarify that a little bit more if I'm not answering it correctly, and to send you the studies.
Great, thank you, Sarah. Thank you. We just had one last question. It's kind of been on my mind too. Does anybody know who manufactures triclosan?
Yeah. So this is Sarah. There's a number of manufacturers in China and in Asia, and Trevor mentioned earlier that triclosan in water, when exposed to UV light, produces dioxins. But actually, the production of triclosan, especially in some of these developing countries, has been shown to be co-contaminated with other dioxins, including 2378 dioxin, or TCDD, which is one of the more toxic dioxins. But the triclosan that's used in products like Colgate Total and some of the other major brands is produced by a company. Well, it was called Ciba-Geigy, and then Ciba-Geigy was bought out. But they are the major manufacturer. And my understanding is that triclosan that's produced by that pharmaceutical company is more pure. It doesn't have the contaminants of dioxin, although it still has the concern that when it's put out into the environment and exposed to UV light, some of the other dioxins are formed, as well as chloroform.
Great,
well,
thank
great.
you.
Thank you to all our speakers for a great job and really interesting topic, and thanks to the audience for attending today's Tricky Case of Triclosan webinar, as well as this is the last in our series of 4 food pollution webinars. And as previously, within the next day or two, on our website, you'll be able to see a rebroadcast of the webinar that's downloadable. So if you have friends or colleagues who missed the webinar, you can direct them to sign up at Healthy Food Action, and they can get access to that rebroadcast. In addition, we'll have a resource pages on triclosan, as the presenters mentioned, and you can find other resources too on some of our other themes. Priority themes include saving antibiotics from overuse, industrial meat, and another series that we just started on food justice and health equity. And then finally, we're going to be launching a new series on an authors series where you can meet on webinars the authors of some of the intriguing books on food and health that are coming out. So thank you all, and please stay in touch with Healthy Food Action and see opportunities for you to advocate around the issues that you hear in these webinar series. Thanks for your time.
Thank you.
Thanks, David.
Thank you.
Thanks very much.